Although weight loss through dietary habits is the most effective strategy to lowering the systolic blood pressure, physical exercise will also decrease the top number, the systolic number, about 5 to 8 millimeters of mercury. I would like to talk more about the DASH diet. It is the largest single contributor to blood pressure reduction. This includes whole grains, vegetables, fruit, dairy products, lean chicken, meat and fish, several nuts, seeds, and legumes. There are various books and CDs and templates online that an individual can purchase. I included a picture of the DASH diet for beginners that can be a good place for many patients to start that are unfamiliar with this diet. This DASH diet will reduce systolic blood pressure by approximately 11 millimeters of mercury. The sodium restriction, which is no more than 1 teaspoon of sodium or 2,300 milligrams per day, will reduce the blood pressure by 4 to 6. Increasing the dietary potassium will reduce the blood pressure by 4 to 5. Not only is this diet beneficial to lowering hypertension, it also is known to decrease risk of cancer, lower metabolic syndrome risk, lower diabetic risk, and decrease overall heart disease risk. According to the latest JNC8 guidelines, the pharmacological therapy for lowering blood pressure is as follows. In the non-Black population, they recommend using thiazide diuretics, calcium channel blockers, ACE, or ARBs as initial therapy. You're supposed to follow up with the patient in approximately 1 month, and at that time, the initial drug can be increased and/or a second drug can be added. And this also includes patients who have diabetes. In the Black population, thiazide diuretics or calcium channel blockers are the 2 drugs that are recommended to start initially. Similar to the first category, a second drug can be added or initial drug can be increased at 1 month follow-up. For people who have chronic kidney disease, ACE or ARBs are initial treatment, as these are the most kidney friendly. The maximum dose of drugs to be added is 3 drugs in the primary care setting. Evidence shows that the ACE or ARBs in the kidney population improves the overall outcomes for this population. Precautions with prescribing include thiazides. You want to watch for the electrolytes and the calcium levels, as well as the uric acid levels. Calcium channel blockers, you want to watch for lower extremity edema. With the ARBs, you never want to use that in combination with an ACE inhibitor or with a history of angioedema. Additionally, you would need to watch for the potassium for both the ACE and the ARBs. A common side effect of the ACE inhibitors is a persistent dry cough. You would consider referral to a cardiologist or a nephrologist after you've put the patient on a 3-drug treatment plan and they have still failed to achieve adequate control of hypertension. You would only want to refer after you have ruled out other causes, performed at-home monitoring or ambulatory blood pressure monitoring to rule out white coat hypertension. You ensure proper blood pressure equipment, proper placement of the cuff, rule out ETOH and medication issues that may be causing the high blood pressure, and rule out other secondary causes. A dietitian may also be helpful. This last slide here are the references that I used to create this presentation. Thank you very much.